Good afternoon, everyone on the East Coast. This is Jonathan Colburn from BioPub here with our friend David Lucci of Acurx Pharmaceuticals. I imagine everyone on this call is well aware of the company. We've been following it for years before it was private, or while it was private, before coming public in, was that 2021 or 22, David?
21.
And so I know many of you have been invested for a number of years. David's here to give us an update and kind of just talk some things through. So David, take it away. I know you just had earnings, so you probably all the world is your oyster as far as what you can say.
Yeah, it's a wonderful thing when we can be fully transparent with folks. We were able to get the FDA to respond more quickly than they needed to on the meeting minutes for the recent FDA meeting. And we were able to sneak those into the earnings call and put them out pre-market on Wednesday, the day of the earnings call. So hopefully everyone has had an opportunity to see that press release. Basically, what it means is that the FDA has green lighted our going to phase three, and the phase three trial design is going to be the same as the phase two B trial design that we recently completed. Meaning that it was 1-to-1 randomized of our lead antibiotic candidate at ibezapolstat up against oral vancomycin, a standard of care antibiotic to treat C. difficile infection. So we have the exact same trial design. And we had a conversation with the FDA about switching the statistical modeling from per protocol population to MITT, or modified intent to treat population, so that we could, continue our plan, which is to do these two phase three trials in a way such that we won't need more trials in Europe and the UK in order to file for approval in all of Canada, US, Europe, and UK at the same time. So in Europe, you need MITT population statistics. So the FDA is comfortable with that. So everything worked out exactly as we had hoped. So we are now officially phase three ready, and working on strategies to raise the resource to do phase three.
I imagine there's gonna be a lot of questions around that, but keep going.
Um, well, that's really about it. We wrapped up the quarter with about $9 million in cash. Of course, we have the ATM up, is allows us the flexibility of another 10 million should we need it. And At this point in time, we're looking for a rest of world partner. That plan became active on Wednesday when we got the release out with the FDA news, which kind of that FDA news puts a nice bow on your package. So what we're doing is looking for a rest of world partner who can share risk going forward and provide funding that we will be able to use to conduct phase three.
So, David, a couple quick questions. Going back, talk to me through kind of what the difference between an MITT analysis would be versus kind of, the general, because usually it's ITT, right? Not a per protocol, but the internal intent to treat.
MITT, it takes out protocol violators.
Okay.
So those who maybe they don't take their drug when they're supposed to, or they stop taking their drug. Um, Maybe they develop, I don't know, irritable bowel syndrome or something like that during the dosage of the drug. So usually when you go from ITT to MITT, it's usually about 5%.
So that's quite a huge gain. I don't think that that's really kind of appreciated enough. When I was reading through it, it's kind of, from the transcript, noticed it, but didn't really think kind of enough about that. I mean, obviously this is, for C. diff as opposed to something like, cancer, that kind of thing, where it's really kind of a long term, right? Because this is going to be, I think, what's the regimen for being on ibezapolstat?
So it's a twice a day dosing, 225 milligrams twice a day. I'm sorry,
For how?
450 milligrams twice a day, but each pill is 225 milligrams. So
Yeah.
2 pills uh, twice a day, 4 pills a day,
For how many days?
10 days.
Okay. So, I mean, obviously, 4 pills, 10 days, you're going to get some people who don't always follow that. They're going to get some took three, took five, did it for 8 days, felt, over my C. diff, I don't care. Those kind of
Yeah,
people. Yeah.
you know I'm sorry to interrupt you, but if you think about it, some people that don't like to take medicine,
Mhm.
like a lot of the old time Italians are like this that I know. They don't have diarrhea anymore. What do? They stop
Yeah.
taking it.
Yeah. Yeah. Which can sometimes create quite a few flaws in the data, of course, because that doesn't always eradicate the issue. Although we can get to the 3-day cure rate with abizepolstat later on. Uh, and once people stop taking it, there's a chance that the disease can, or that the infection can come back, skewing your data. But here, that won't be an issue.
Won't be an issue. And I think our we're reasonably enthusiastic at the FDA's kind of tone. They seemed it seemed to pique their interest that we don't have any reinfections.
Hmm.
And of course, it's been something that makes our data stand apart from any other data we've seen in C. difficile. Having no reinfections in 25 patients on our drug in phase 2. If that data holds up in a stat sig phase 3 trial, then it's going to dramatically reduce the $4.7 billion cost burden on U.S. public health every year,
For
which
the
is
recurrent,
entirely related to reinfections. Yes.
right. And I imagine that there's a number of companies that are looking at that are kind of dwelling in the recurrent C. diff space that see you as quite the threat. So, I think that that's a secondary endpoint, right? The 30-day cure rate is one of the that the FDA has allowed.
Yep.
Uh,
Yep. That they
that'll
call
be a,
that sustained clinical cure 30 days after end of treatment. Yes.
yeah. So
And
that'd be
that's
yeah,
something I've talked with Dr. Mark about a lot.
yeah,
Series Therapeutics, they have Voust,
yeah.
and Voust claim to fame is if you take it second line, you can't take it first line. It reduces reinfections by 88%. But how do you get to second line if you have a frontline antibiotic that doesn't have reinfections?
Absolutely. So again, try to keep the competitor's name out of it, but they've got to be looking over your shoulder, kind of saying, let's hope their phase 3 takes a long time so we can keep.
Yeah.
Um, yeah. So let's talk about the phase 3 then. Obviously, it's 450 patients, right? And that'll be between two different trials, correct?
It's 450 patients per trial.
Oh, per
So,
trial. Okay.
yep,
Only
225 patients per arm,
uh,
and a 2-arm trial done twice.
gotcha. Okay. So and obviously arm one is vancomycin, right? Standard of care. And
Yep.
arm two is ibezapolstat.
Yes,
Uh,
10 days for each.
and fingers crossed that we won't have the weirdest, strongest vancomycin arm ever with a 100% clear cure rate. That was
Well,
unprecedented, frustrating.
yeah, I mean, as unprecedented as it was still clinically comparable. So it didn't beat us. It was
Oh, of
just the
course.
same. Yeah, yeah.
Yeah,
So if we just do exactly the way it happened last time, and they're 100 and we're 96,
yeah.
that's a win. That's a box checked on the primary endpoint.
The
But
inferiority.
then what the FDA is going to see, and doctors that prescribe are going to see, is that we don't have reinfections, and because Vanco is so broad spectrum, it has many reinfections, about 30%. So that's where we really will stand out. And remember, we have the patents on use of an antibiotic to treat C. diff and restore a healthy microbiome, which is highly unusual for an antibiotic.
Mhm. And when you say you have the patents on that, I mean, is there a potential of using that as a kind of not in a C. diff medication, but as a just kind of microbiome ameliorator? Or am I just kind of reaching?
Yeah, the reason why that's a little bit of a reach, and it's been asked before by some smart Wall Street analysts. Um, you don't know, excuse me, you don't know the nature of the microbiome imbalance, right? So if you're attempting to restore the microbiome in a patient who does not have C. diff,
Yeah.
that patient maybe his disrupted microbiome, his imbalanced microbiome might be characterized by having too little C. diff.
Uh-huh.
So then if you give him ibezapolstat, you're making him actually worse.
Yeah. And I think that makes a lot of sense. I had been intrigued by the way you'd mentioned the IP, but that makes a lot of sense. And the fact is that we don't really know enough per se about the microbiome to say this is what each individual needs to have. Although certainly we do know that when a C. diff infection happens, we know what it doesn't need to have, which would be that rampant C. diff going through it, hence the side effects of
Yeah.
yeah.
You know what, Jonathan, if you think about the microbiome, right, it's like a fingerprint. It's different in every person. And how do you get a disrupted or imbalanced microbiome? Most of the time, it's because you've been, overusing, one antibiotic or another. And different antibiotics have a spectrum of activity against different of the healthy microbiome classes.
Right.
So, every person may have a different, kind of imbalance from every other person. Like somebody that's on amoxicillin, it might be different if you're on levaquin. You know what I mean? It depends on what bacteria are susceptible to the medicine.
Yeah. Um, Well, yesterday, if I remember correctly, the University of Houston, you guys co-sponsored a kind of a bit of a antibiotic, the Houston C. diff and Microbiome Conference. I imagine you weren't there, but Dr. Gary was.
Yes.
How did that go?
Um, I don't really have an update on that.
Well, just I saw that you guys had been co-sponsors, so I was interested to see kind of how that's going. He's obviously a wonderful proponent of the company and the drug.
Yeah, no, he's been great. He's a world leader with the microbiome. He's going to present on our behalf, I think, at 3 or 4 more scientific conferences throughout the rest of 24.
Oh, very cool. Yeah, he's going to be a real jet setter by the time this is done.
Yeah, he just got back a month ago from Barcelona on our behalf.
I will also help go to Barcelona for Acurx's behalf if you'd like.
Yeah, yeah. Uh, I wish I could have gone, but our chairman was there at the booth as usual.
Yeah.
Yeah, the little Acurx booth right across from Pfizer's $300,000 extravaganza.
It's a little different of a world, isn't it? Well, I
Yeah.
hope I saw you and I I when we were talking, kind of at the beginning of this webcast, you mentioned that, what you guys are looking for is a global partner, right? Kind of to take it to phase three.
Uh, we're looking at more for like our primary we're open.
Uh-huh.
Our primary interest is a rest of world partner.
Sorry, yeah, rest of the world, non-US, I assume.
Yeah, so we're open to everything, but we think if we could, it might be kind of the best for us and our shareholders if we had a partner that had rights outside of North America.
So talk me through that rationale. If I remember correctly, I've seen, in some places that some of the best recruiting for other phase threes has been in Europe. So having
Yes,
kind of boots on the ground there could be helpful, obviously. So a partner, a rest of the world partner who's got that experience in Europe would certainly be helpful.
yes,
Is there
indeed.
more out of that beyond?
Oh well, so the way we worked it out with the FDA, the phase 3 trial design now meets European criteria.
Mhm.
So, and as you know, we're setting up our phase 3 program to have international trial sites with a heavy emphasis on Europe.
Mhm.
So the phase 3 data that's generated will be fileable for approval in Europe, the UK, Canada, and the US, without having to do more trials.
Yeah.
So if we had a European partner, we would be able to, potentially lay off some portion of the cost of phase three, because we and our European partner or European Japan partner would have the opportunity to use all that data to file for approval in the various countries around the world.
Hmm.
So it would really make sense, if they have internal capabilities and we don't even have to hire a CRO.
Yeah.
I mean, then that would just save us millions of dollars right there.
Yeah.
So
And
that's kind of, so then, the general structure, I think you're going to ask me. Maybe I should wait till you ask.
go ahead.
I was going to say the general structure that you get in they're called licensing and co-development agreements. And you get an upfront payment, you get clinical and commercial milestones, and then you get a royalty, sometimes a tiered royalty, sometimes not. And that's kind of what happens. And then the rest of it is negotiated, beneath that.
Yeah. And sometimes is or is not public, at least for a while.
Oh no, no. If we sign a license and co-development agreement, it would be a material thing for the company. So we
I
would.
mean, as far as revenue sharing, that sometimes and profitability, sometimes those are kind of kept below the belt as far as giving you the leeway to negotiate other territories if need be.
Oh, I hear what you're saying. You know
Yeah.
what? The money is going to be some material to us. I think we're going to have to disclose it. The way I've seen it in the past, usually you talk about bio dollars.
Yeah.
You know what I mean? And that's a
Yeah.
good way to keep it general, like you say.
Yeah.
So you say in a deal, totaling blankety blank bio dollars.
Yeah. And obviously, with the phase three minutes in hand from the FDA, the quote unquote outbound calls, I always enjoy. I think I learn new terminology from you every time we speak. I really appreciate that. The new addition to the lexicon, the outbound calls now that the kind of the phase three meetings or minutes are in place. That's begun, correct?
Well, it hasn't begun since Wednesday, um, but
Okay.
it's about to begin.
Yeah.
The last piece of it is to review and sign off on the pitch that our M&A strategy guys are going to use when they make the calls.
Yeah. And
The
that's
calls will start next week, but it's also nice too because now that we're making these calls, now I can reach back to the people who made the inbound
Mhm.
calls with interest. I
Absolutely.
haven't I haven't wanted to respond to anyone other than follow up requests, but I
Yeah.
haven't wanted to kind of push anyone because it's all about pricing tension. You want to get everybody kind of in a timeline to with one another
Mhm.
so that you can kind of maximize shareholder value.
Yeah.
So I didn't want to reach back to people who called us with interest before I started picking up the phone and calling the new people. And I didn't want to call the new people until I had the FDA news.
Yeah. No, it makes sense, right? It's all of a piece. So you've got to kind of have you got to have the table set for you can kind of really make those decisions, kind of see what all is out there. And, you know, inbound interest is very good, but obviously, sometimes negotiations, you don't always take the first phone call is not always the best one. So kind of
Well,
setting.
if you've been invested in a company that's been sold before, right? You,
Yeah.
you see like the S4 merger proxy,
Yeah.
right? And in it, in somewhere in the first 10 pages, you see, the you know kind of the timeline and activities that led to the
Merger.
signing of the merger agreement,
Yeah.
and it goes through by paragraph a chronology.
Yeah.
On this and such a date, we hired somebody. On such and such a date, we had our first conversation with Pfizer. On such and
Yeah.
such a date,
We called whomever.
we received a term sheet.
Yeah. Yeah.
Then on this day, right down to the day, on February 15th, we met with the board of directors and discussed blankety blankety blank. And so you really gotta to show that you've kind
Done your due
of.
diligence for you have a fiduciary interest for all the investors. So
Yeah,
certainly appreciate.
exactly. So if you get an offer, you really, unless it's like crazy high, you know, you gotta, kind of do other things to exercise your fiduciary duties, as you say.
Yeah, that makes sense. And obviously, we're not saying that that's what's happened, of course, but obviously that's all part of the piece of the kind of two-pronged plan that's going on for your company of phase three readiness and you know whatever strategic insight may or may not happen.
Yeah, yeah, and then, one of the next steps is, of course, the bio CEO partnering meetings that'll happen in the first week of June.
For those who tuned in either a minute afterwards, the first 10 minutes while we logged on before the actual recording started, David was going through 200, 300 emails, it sounded like, from Bio CEO. So certainly some level of interest in meeting with him.
Yeah, there's a lot of partnering interest. I will say that, out of those 300 folks that want to meet, a good wedge of them are vendors.
Yeah.
That
Yeah.
I've even noticed, Jonathan, some of these other companies like Acurx, I see on their message where they put in a brief description of the company. They say point blank, no vendors, please.
It's tough out there for vendors. Hopefully they get their drinks and all that comped at some point.
Yeah.
Um, so I mean, I guess talk to us since that's in 2 weeks. What Bio CEO is? I think it's pretty clear from the name, but it's out there in San Diego. Take it away, David.
Yeah, it's a networking event where big pharma, small pharma, biotech has an opportunity to meet investors and one another for purposes of financings and partnerships.
Yeah,
When I say partnerships, that includes M&A, of course.
of course. And it's certainly something I think Bio CEO. It's been around for what 10, 12 years, maybe more, but
I
it's
think, yeah.
it's obviously it's not JPM levels yet, but it's becoming a more and more kind of a lot of hands get shaken or shook at this that for deals that happen later on. So it's certainly a very good place to be and to meet people.
Yeah, it's almost a more balanced. JP Morgan is obviously the premier conference of its type, but other banks obviously can't attend it, right? You can't
Yeah.
other banks can't get into the JP Morgan thing. Whereas at Bio CEO, you have bankers and business guys, all at the same event, kind of hosting the same companies and looking for clients, and it's just a very dynamic, energetic environment. So.
Well, good. Well, best of luck. Will it be just you, or are you taking Rob, your CFO, as well?
No, I'm a one-man band. In fact, I'll have my computer with. There have been times where I've been, I take my computer with me.
Yeah.
I talk to somebody. I'm not suggesting that it'll be this time, but you have a conversation with someone, you expect it to be good, it ends up being great, and I just flip up my laptop and just start drafting a term sheet. And the beauty of my background is, I can, kind of talk through terms
Mhm.
and draft the document and sign it if everyone's agreeable.
And if you could give us a little light on your background, you're not just the CEO, you're also, I think
Oh
that
well,
you,
yeah, I'm an M&A lawyer, contracts lawyer. I've done a ton of financings at a law firm for 8 years before I went into my first biotech company. And I'm also an Ernst and Young auditor from their healthcare practice group, all in New York. And I did both of those positions together for 11 years before going into my first pharma company in 2002.
so a little bit of experience, just a little, and
Yeah,
good to see.
but I tell you, when I see what some of these other guys have to do. You got to get your CFO involved, and I started as a CFO general counsel, and then they got to get outside legal and this and that, and I'm just a red tape cutter.
Yeah, well, we appreciate that. A couple questions for you. And obviously, sometimes you can answer things, sometimes you cannot, and I get that. Chris is asking, can you describe the clinical course for the one patient in the recent trial who was not cured by abisapulstat? I think Chris is trying to wonder whether or not the MITT approach would have weeded this individual out.
The individual was a protocol violator, so yes, he would have been weeded out.
Gotcha. And any color you can give on what type of violation and how that happened? He just didn't take it, or if you can't, we get it.
Um, don't hold me to this, but I think he had like irritable bowel syndrome or something like that.
Mhm. That would, yeah. Uh, Karen is asking kind of if you could give a little more color on the term biodollars, which in essence, sometimes people say it's a $1.5 billion deal, but the answer is it's really $100 million up front and then 1.4 million in milestones, revenues, etc. Karen. And
Yeah, I would say yeah. So, upfront payment, clinical milestones, commercial milestones, and then the royalty is kind of outside of that. So the bio dollars would pick up the clinical and commercial milestones and the upfront payment. And in our case, if say for example, hypothetically, if we were splitting 50-50 the phase three costs, that would get picked up as kind of like the same as like a clinical milestone.
gotcha. Um, my friend anonymous attendee, based on the earnings call, there will be two phase three studies totaling 450 patients, and I got that wrong at first as well. It's 450 each. Uh,
Yes,
aside from increasing the number of trial sites and going international, what changes will be done to ensure the trial enrollment ends on time?
on time is a it's kind of like a catch 22. Um, so I don't know if there's an on time, um, but what you do is you try to throw everything you can against the wall and see what sticks, right? So we're going to have four times or so as many trial sites as we had before. And a lot of those trial sites going to have a heavy emphasis on Eastern Europe because we hear that that has enrollment rates that are very high relative to the slow enrollment that folks have been experiencing here in the U.S. So we've also, it's like having a big brother. We look at Summit Therapeutics and what they did,
Yeah, I was
and
going to.
we're able to go to school off of that, right? So Summit Therapeutics, for all the bad they did, you remember they had ridenolazole and it failed phase three, but they enrolled their phase three trial. They got 750-ish patients in 2 years' time,
Yeah, that was
largely in
during
Eastern
COVID,
Europe.
right?
So what we've done is we've hired one of the enrollment experts that they used to kind of get enrollment to pick up. And I'm sure Summit doesn't care. They're an oncology company now. They're not even in the space anymore. So
As you do, yeah.
yeah, so we're working with the same specialist who knows, you know, who knows to call bullshit on a trial site that says, yeah, I could do 10 patients a month.
Mhm.
Like this is a person who's got the insight to know what the real numbers are.
Yeah. So that's impressive hire because, I think Summit, that was in 2020 to 22, right? That they did that.
Yeah, I think that's right.
And that was quite a challenging time, to put it mildly. And, I think there's thoughts that maybe, Eastern Europeans haven't really changed their, kind of their mannerisms the same way that a lot of Americans have. And that, a lot of times, if you've got vancomycin and you don't have to go to a trial center versus entering a clinical trial, uh, Eastern Europeans appear to be far more interested in trying this out, doing what they can, versus a lot of Americans have just been staying home and do a teledoc, which is going to give you a standard course of vancomycin.
Yeah, that's right. I gotta give you like two more little bits of color on that though, which
Sure.
I think come up. Another thing, the first is another thing that Eastern Europeans do that Americans are doing less and less is they go to work in the morning. you know. And when I say that, I say it tongue in cheek, but
Yeah.
if you have C. diff and you go to one of our trial sites,
Yeah.
if you don't have both of the site administrator and the principal investigator present at work on that day, you're not getting in.
Yeah.
So, you know, I mean that's a big problem. The second little piece of color I would provide is the one change I notice the scientific team is giving us one extra whole day to get a patient from initial diagnosis into the study as an enrolled patient. So you may recall in the phase 2B, they only had one day to go
Yeah.
from. So if you go to the doctor and you got C. diff Monday at noon in, say, Palm Beach Gardens, and you got to get down to Miami by Tuesday at noon,
That's
I
it's a
mean,
tough turnaround. Yeah.
especially when you got diarrhea like you've never had before. I mean, how long is it going to take you to get, you
Yeah.
know?
That's a challenging drive. Hope you drive the old car. But yeah, it's a very interesting and like underappreciated point, right? So having that, that longer turnaround, having that kind of, there's more of a cushion for someone to come in, start the trial, enroll, and become part of the actual trials. Probably going to be one of those things that really you wouldn't think, but it's going to add a lot of potential to enrolling more quickly.
Yeah, I think that's right.
Um, David, a couple more questions. Obviously, cash is going to be a conversation to have. The question here is, what is the current burn rate and what are the salaries for executives?
Um, the salaries, I think in the proxy we have our salaries. People can look at our proxy statement we filed in April.
Mhm.
I think salaries, me and DeLucia is the highest at about 485. I'm at about 475. Shaw, I think, is at 375. Don't quote me. I mean, look at the proxy, but
Okay.
that's my recollection. We have a controller as well. She might be at like 135. Um, and that's about that. What was the other? Oh, the quarterly burn without phase 3 being conducted, with no clinical trials, just G&A patents. We're about 1.5 million a quarter.
Yeah, so that's pretty slim. It's good
No,
to see.
actually, that's close to 2 years of cash.
No, that's what I'm saying. No, slim is in like as far as the burn rate. I was going.
Oh yeah, yeah, yeah. No, but I mean, with our ATM, we have plenty of time to find a partner
Yeah,
or do a
and,
financing or however we're going to piece it together. Maybe a little of both.
yeah, and you've got 9 million in cash now, right? And that's what you're alluding to is that's about 2 years of cash at that 1.1 burn rate.
Well, it's the nine plus we have 10 on the ATM that we could always tap
Well,
if needed.
yeah, if needed, and you've got 15 million about in shares outstanding.
Yep, 15.8.
Yeah. Okay, so
Oh,
close.
and don't forget if we get a nice run in the stock, we still have 14 million plus that'll come in from warrant exercises from one of our institutions.
Yeah. Okay. So that would obviously affect the cash and of course the shares outstanding. What are those
Well,
warrants?
the
Yeah.
nice thing about that is it's kind of almost non-dilutive, right? Because you're just on your cap chart, you're just taking it from one column and putting it into the other column.
Yeah. Two total shares.
Yeah.
And I forget what do those convert at price wise?
In the low threes, like 320, 325.
And
They're not
expiration
all the same. They're
and
it's a
expiration
mix.
deposits. Yeah. And how long are they until they expire? Do you remember? I keep trying to put you through the paces on your on your 10Q.
Yeah, they were from different deals. So they were 10-year warrants from a couple of different deals. So there's probably 7 or 8 years left on one and 8 or 9 years left on the other.
Gotcha. Okay. So that's, not really an overhang per se, so much as hopefully an opportunity for them to be cashed in for the company at some point.
Well, yeah, it would be nice to remove it as overhang
Yeah.
and get the cash. Be a nice double whammy.
Um, Karen's asking the new enrollment expert that you've hired from Summit, did he or she have any insights to share on trial design at this time?
No, they're not experts in trial design. They're experts in enrollment, and it's a she, by the way.
Uh-huh. Let's see. Rich is gonna, I think, dig into the proxy to double check the numbers. He was thinking 600 for you, which by the way, you and I can gladly change positions if you'd like. Although I don't know if I want your 300 emails from Bio CEO now that I think about
600. Wow, that sounds pretty good to me. I'll sign.
it.
I'll sign on to that. I don't know where he's coming up with that, but maybe that includes bonus. I don't know.
Could be. Chris is asking, saying, great news about the additional day to get enrolled. Always thought that one day was a big impediment. What's the cost of a standard course of vancomycin, and how would that cost compare to the expected cost of a course of obesidipulstat?
Okay, so our we need the phase three data to do a formal pricing study. Um, because it's going to impact what that pricing study
Right.
will yield. But having said that, we could price anywhere. Vancomycin is $1,800 for a 10-day course of treatment. So that's $180 for a day times 10.
Yeah.
Fidaxomicin is 5,000. It's branded. And our cost of goods is going to be, somewhere in the neighborhood of 200, 150, 250.
For a
So
10K.
for a 10-day course of treatment. So yeah, we could price anywhere. I mean, I don't think we're going to have to beat vancomycin because no one's going to use it anymore, and it's going to come off the recommendation list, at least according to the people that write the recommendation list. Um,
So
with the next good antibiotic that's approved. So I think we're going to wind up having a price competitively against Fidax.
interesting. And I want to talk about the people who are, you're talking to, because when you look at your company's, you know, all the people you're surrounded with, those are some of the experts in the, C. diff space. Like your, I can't remember which board it is. You've got obviously your M&A board, but the science board, there's some luminaries of the entirety of the field.
Yes, our scientific advisory board includes the four drafts people of those treatment guidelines for C. diff. So they're the ones who a few years ago they took metronidazole right off the recommendation list
Uh-huh.
in the IDSA treatment guidelines. And at that time, they told us that the next antibiotic that has good data and gets approved for treating C. diff is going to mean the end of Vanco on the recommendation list.
I did not realize that those, I mean, the days of Vanco are coming to an end. So that's interesting.
Well,
Uh,
it was first approved in 1959.
it's
You
59.
know, I mean, you don't hear people taking penicillin anymore. You know, sooner or later, antimicrobial resistance is going to eat up any drug.
Fair enough. Fair enough. And so, again, if you have to go head to head with fidaxomicin, which has, I think, what, an 88% cure rate generally versus 84 or so for Vanc.
Something
Pretty,
like that. And it's got a little bit better on the reinfections.
yeah.
Maybe they lose maybe 15% to reinfections,
Mhm.
which is better than say 30 for
Yeah.
Vanc. But we're
It's,
not going to have, I mean, we could go head to head against Fidax. We don't have to for phase three, according to the FDA.
it would also
Um,
cost more, obviously, because you'd have to be securing that drug versus Vanc.
yeah, we could do a marketing study, that's been talked about after the FDA approval, just to help differentiate. And, we would kind of think hard about that, but you can't make that decision until you see what your data is.
Fair enough. Um, John is asking, David, a few years ago, your expectation was for a smaller initial P3 and then a larger second one. Can you comment on why the increase in the population, and it seemed both studies will be the same size instead of a smaller followed by a larger?
The smaller followed by the larger was a higher risk approach,
Gotcha.
because statistically, you could fail on that smaller, um, because it's less patients. So you're trying to show separation, and you want to give the true, if you believe that the real outcome is that you beat your competitive drug, the smaller the group, the more difficult the statistics become to make sure you get a win. So we wanted to, kind of be real comfortable that we have enough patients to get a win. We still may do the trials consecutively instead of at the same time.
I was going to ask, so what's, obviously all things are, subject to change, forward-looking statements, whatever else the general counsel, CFO role would like us to say. What is the thinking here? Is it consecutively or, you know, uh, what is it as far as the P3s go?
Yeah, I mean, we're going to be open in our discussions with partners. I like the idea. Again, going back to Summit Therapeutics, they decided that they were going to do both their phase threes at the same time. If you go back and take a look at their disclosure, they're public, so you can see exactly what they did.
Yeah.
So they ran the two phase threes at the same time, and then kind of had a come to Jesus moment and decided halfway through both trials that they didn't even meet the FDA to get clearance for this, which is
That was,
mind-boggling.
that was the
But
death knell.
they fused the databases together so that they could get an idea and unblinded themselves to get an idea if they should keep going. Futility analysis. Are we winning? Is it close? In other words, should we spend the other whatever it is, 25 million on, in their case, it's probably 50 million on the other half of the two studies?
Yeah.
Or if it's not looking that good, maybe we could save 50 million.
Yeah.
So
And
from that perspective, I kind of, for my 2 cents, I like the idea of continuing to do these things consecutively because then you can get the data from the first trial.
make it.
And if you got to win, then you can go, you can invest more money in the second trial. And you're not really losing anything on the back end in terms of commercial protection because, you got the 10 years of regulatory exclusivity in the US, and I think it's 9 years in Europe.
Yeah. So yeah, and that's from the QIDP status, right? That you kind of you get that, and you've got the exclusivity for however long after approval. So I get that, unless of course, and I haven't looked. I'm sure you would know better than I whether or not there's other competitive agents in the past that are, further behind in development that could be kind of encroaching. But that's a kind of conversation to be having with the partner versus, kind of how that would go.
Oh yeah, yeah. That's why I say just talk about my preferences. But
Yeah.
you're exactly right. It's in a partnership, it's almost like drafting legislation. You got to give something to get something, and you come out in the middle on some things.
Um, there was a quick kind of commentary about your salary. Sorry for that. But just to clarify, David's salary is 475, and then there is a bonus on top that gets closer to that number that was first brought up.
I
Um,
mean, bonuses though, they could be zero. There's no guaranteed bonuses. The only thing that you're getting is your base.
gotcha. Chris is writing aspirationally, and I agree with him here. Next time you're looking to raise money, would you consider giving BioPub members a chance to participate? He would love to have been offered the deals that Acurx has offered in the last, with the warrants and such. I know that at some time.
We're probably not going to do another round that the biopubbers could participate in. If we did another round, I think it would be like an institutional round. So the last time, when we filed the S1 recently, we didn't even have a chance to come in. So,
So
um,
I think that's an interesting thing. I'm not sure people appreciate kind of, we had the S1 put forth and then retracted, right? And maybe if you want, you could talk, David, about the, kind of the mini shelf, the 1 year kind of for an under $75 million market cap company and the amount of S1s versus S3s that due to the market cap considerations, uh, you know, kind of had your hands tied, if you will.
yeah. So I'm sure your folks know about the baby shelf rules, right? If your public float is under 75 million, then there are limits on how much you can raise on what they call an S3 registration statement. That's a short form. It's quick, it's confidential, and it's cheap. Versus an S1 registration, which is the long form, which is public. It's not confidential, and people therefore know that you're out raising money.
And then they sell in short.
Exactly, exactly. So, this past, when we filed the S1, we withdrew it because after a couple of weeks of marketing, our price declined from low threes to mid ones. So we were like on the interstate.
Yeah,
And when we looked at that price action, realizing there was going to be a discount to whatever the market price was on the morning that we were closing, we didn't like the deal anymore. We thought that sometimes it's the deals you don't do are better deals than the deals that you do.
yeah,
So we didn't want to issue 55%
dilution.
of,
Yeah,
more than 100. In other words, we had about 15.8 million shares outstanding. We would have issued way more than that if we were to close our deal. So we just withdrew the registration statement with meetings left on the table. And we were like, we got some money, we got an ATM, and we got a drug. So let's uh
and
let's go with our best foot forward. We don't want to do this deal.
the remind me, so that the baby shelf registration is for 12 months, right? As far as, so you would not be able to, you could submit a secondary of another S3 after November, December of this year.
It's the same S3. What we could do, the S3 is limited by the baby shelf rules. So we have a $50 million S3 uh, shelf registration statement that's effective. But to access it, you can only access a certain amount, which changes every day based on your NASDAQ market price. Um, and you have to back out all other financing efforts that closed in the last 12 months. So I think I was explaining to Jonathan last week, once we get to November, the end of November, we won't have any more backouts on our shelf.
Right.
So after November, if we decide to raise money, no one at the pub will know about it. No one in America will know about it until we close.
Yeah. And that
And
makes
then
that,
when we close, we'll put out a press release. And then if people want to get nervous, they get nervous. If other people want to say, hey, they got the money they need for phase three, let's double down. It's good. We have a retail base, so it's like a fingerprint. Everyone's gonna have a different reaction.
yeah. It's, that's something that we don't see too often as far as the baby shelf rules, but it's something I'd completely forgotten about. So when you reminded me when we spoke either a week or two ago about it, it was one of those dawnings that made me feel either old or forgetful or both, because I'd again forgotten.
Yeah, no
Uh,
problem. The important thing to know is that, you know, it's just another lever that we have
yeah,
in the quiver of arrows to raise money effectively. The last thing you want to do is an S1.
absolutely.
We just thought that, we wanted to be aggressive, and if we could have gotten the deal done at $3 a share or something in the low threes, that would have been a nice win for us.
Yeah,
But in the low ones, you
yeah. That's,
know,
as a shareholder myself, who has bought far higher than $1.50, I was quite happy that you had, taken the S1 and repealed that. That works well for me. And I think the share price kind of alluded to that as well.
yeah, I mean, we've bounced back nicely since then. So,
Like to see it back in the threes from when before the S1 was submitted, but we'll see what happens.
well, look,
Uh,
if we get a partnering deal in the rest of the world, I'm hoping it's a lot higher than three.
you and me both. I think that everyone on this call would definitely agree with that sentiment. John's saying that he had a little bit of an audio issue on his end. Uh, what are we looking about for the entire phase three cost? And apologies for if that was duplicative.
Yeah, no, I mean, uh, in answer to that, number one, we don't know, and number two, we don't know because we don't know we don't know who's paying for what and what their internal capabilities are.
Fair enough.
Right? So what I can say for John is that if we have to pay for it on our own, it'll
Yeah,
be ballpark in the 50, 60 million ish range.
right.
But we're entering partnering discussions here with folks that have, in many cases, internal capabilities. So kind of like the buildup that we use to get to what we would pay for with a CRO and whatnot, if we were to do this independently, it goes completely out the window if your partner in Europe and Japan has boots on the ground that can do most of the work internally, if that makes any sense. So that's why, I mean, it's just preliminary to be able to say,
No, I think that makes sense. And I apologize. I was swallowing water, so I didn't mean to give you that kind of the moment of silence there.
uh,
Um, it makes a lot of sense that it's going to be somewhere on a spectrum around 50 to 60, but how is that going to be done? If you've got a partner, I've got a couple ideas who a potential partner would be, of course, that does trials, kind of constantly running trials in Europe, that's got that footprint, got that built out internally. It's not really a cost for them per se, besides obviously buying, running the trial itself, because they have all this experience and equipment, or not equipment, but personnel in-house already,
yeah,
versus doing
that's
it.
right.
So, you know, that leads to there's a few European companies that come to mind as good 4 or 5 that I think that would be hopefully I've submitted some of the inbound calls and now the outbounds will go to them. But you would know better than I, of course. Um,
Um, yeah, I mean, look, there's the company, a lot of the companies we're talking to have capabilities. And some of them may have partial capabilities, right? Like some of them may be like, yeah, we don't really do the clinical trials. We outsource that, but we do all of our own manufacturing.
yeah. And well, that brings to another question I was going to have as far as manufacturing goes. Uh, do you have enough ibezapolstat on hand now to run the phase threes, or are you going to have to kind of, do another lot for that? Where are you as far as preparedness for that?
Yeah, this came up on the earnings call as well. Yeah, we, had an update on that recently. That project is underway. It started in the fourth quarter of last year. There's no hiccups so far.
Cool.
So we're creating the lot that we're going to need for phase three.
Gotcha. Okay. And that'll be manufactured where? And that may have come up on the call. I just don't remember.
Our primary manufacturer, Pyramel Enterprises.
Okay. And that's where do they manufacture it? Is that
Right now they're making the drug substance, the API in India, and they're using their Pittsburgh facility for fill finish.
gotcha? Anonymous attendee is asking, what is plan B if you can't get a partner or raise funds to move forward?
If we to sell the company, do a reverse triangular merger and go away. I
Okay.
mean, I don't know what else.
Yeah.
How do companies exist? They either raise money or they partner. I guess the third thing would be outside of biotech, maybe you have a company that has revenue.
Yeah.
But
Which
that would
doesn't
be
really.
novel.
Yeah.
Yeah.
So Chris is asking, have you received any firm offers, no matter how unfavorable, to buy either the drug or the company outright?
We can't comment on that. We can only comment on that topic when we have something to
Yeah,
announce.
then that makes sense. So obviously, people watching, if you've got questions, put them out there. Oh, perfect. And I'm glad I spoke. How much is spent for each trial patient in terms of screening? And that may be something that's going to phase three,
Yeah.
two costs are going to be radically different because of the total end and kind of mix of patients, I suppose.
Yeah, I don't have that at my fingertips. I'm not sure. It's not that much. It's the screening process is quick.
Yeah,
I mean, how long could it take? You only got 24 hours to go from diagnosis to get into the trial.
but it's 48 now, and I do really think that that's going to be a huge difference.
Yeah, I think there's a PCR test,
Uh-huh.
toxins test, um, a couple of little things. It's not I don't think it's that much.
Besides the 24-hour window that to 48 now, is there any change in inclusion exclusion criteria from the phase 2B to the phase 3?
Not that I'm aware of.
Uh, a question, are you as confident now as you were 2 years ago?
This may come as a surprise to retail investors, but I'm much more confident now than I was 2 years ago, and the reason why is because
Data.
I can read and interpret the data that we've released.
Yeah. Yeah. And I think that,
You know,
regardless of,
we have a drug. We know we have a drug now,
yeah,
right? 2 years ago, we didn't have phase 2B data. We weren't showing for the first time no reinfections in a $1.5 billion C. diff market, right? We didn't know we were restoring the microbiome well enough to get a patent on it.
it's very good points. And, there's more microbiome data to be coming, right? As far as, kind of presentations and all that,
Yeah, there's a whole lot of it.
which is something that,
Micro,
if I remember correctly, your partners, potential partners, are very interested in because that really is kind of the key to the drug.
the no reinfections, yeah, it's a key. It sets us apart from the other antibiotics.
Well, last call for questioning is, again, we can stay here as long as we want, obviously, but want to make sure that we're using David's time appropriately and, frankly, your time appropriately. Any questions? I think an hour, hour and a half is kind of what I expected, so kind of on course here. And oh, here we go. Uh, Rich is asking, is your preference for a partnership? Was your preference for a partnership or to be acquired before phase 3?
Before phase 3, um, it's tough. My preference, like we were talking about, and it's only one vote, and I'm open minded about it. But I think the best thing, if we could find it, would be kind of a fair rest of world partnership in the form of a license and co-development agreement. And part of the reason why I think that's the best thing for our shareholders now is because our share price is so low.
Yeah. Yeah.
What would we command in an M&A deal? When you're talking about M&A, you can't divorce yourself completely from your NASDAQ share price. You negotiate by saying, we need to get the intrinsic value of our drug. But the other side of the table is saying, yeah, but if I offer you 70% premium to where you are today on the NASDAQ, your board's going to be sweating bullets. No, I mean, you're going to have to think about that, right? And our board may very well say no to that, but where does that get us? It gets us 6 months down the road, a broken deal, and no farther from a transaction that would have helped us. Um, so that's kind of how that goes. When you're doing a territorial licensing deal, it's all about the intrinsic value of your drug in that territory. So it almost doesn't matter. You're not on a daily watch of the ACXP ticker to see how it's going to impact your European license
Yeah.
because it's not. It's going to have no impact.
Yeah.
All that matters is, let's get with the high-end finance guys. Let's go through a modeling exercise and negotiate what the intrinsic value is in the relevant territory, and then you whack it up into upfront payments, milestones, and royalties, and and it's that simple. So that gives us the opportunity, to kind of go long on ibezapolstat, raise the money that we need for phase 3, in a non-dilutive way, and if ibez does what it did in 2B, we'll get a much better deal than 3 per share some point after phase 3.
Right there with you. I mean, I think that, you spell it out probably better than I ever could. But the fact is that regardless, if an M&A premium is 100, 150%, that means we're talking $4 to $5 a share tomorrow. That is woefully insufficient. Whereas if you get a deal for X amount, I won't make it up because I'll probably be completely wrong, that values you appropriately in Europe or rest of world entirely, you can, all of a sudden the numbers start making sense because someone has validated it externally from David Lucci, CEO. And all of a sudden, you can take this drug, de-risking it yourselves, all the way through phase three and getting to the ultimate value that it should have, just with a partner already there in hand to take shoulder that cost.
Yeah, I mean, I would say I agree with that entirely, except I would say that, if you take a look at other M&A deals in our space, I haven't seen a lot of 150%
Fair enough.
premiums.
Deal with too much oncology some days.
Yeah, maybe that's an oncology
Yeah,
premium. Maybe it's an Alzheimer's premium, but I don't think it's an antibiotics premium. But,
I
who
think you're
knows?
right about the antibiotics premium, and sorry to get numbers even larger in your head that
Yeah, but I mean, just while we're on the point, for a little bit more color, it's like if I keep flipping sides here, like if I put my M&A hat on for the buyer, when you go through the exercise of a rest of world license and related, intrinsic value and start putting numbers on paper, how long is it before the partner says, geez, if this is the value and we agree internally that this is the value of this thing, look at what their market cap is on the NASDAQ. It's almost like if you give them a few more shekels, you can get North America for free.
yeah,
That's where you might get into the 150%,
yeah,
you know.
that makes sense to me. You've got anonymous is saying, I hear sometimes doctors or hospitals, even though the numbers are better, are often slow to adopt a new medication and will stay with what's been around, even though that medication is inferior. I think he's asking pretty much, do you foresee an uptake kind of inhibition, even once the drug is approved?
Yeah, I mean, what he's saying is definitely true, and particularly in antibiotics. Um, but you know, people tend to the new branded antibiotic, like a new branded oncology product, is almost always more expensive than the other things that are already there on the market.
Yeah,
So the saving grace for us is that Medicare, Medicaid, and the VA can't follow that philosophy. They will have to use our drug if it's between us and fidaxomicin, say hypothetically frontline, and we're cheaper than fidaxomicin. Then they're going to want then all of those Medicare, Medicaid patients, VA, they're going to want to use our drug first because if they use the more expensive drug, Medicare, for example, is only going to reimburse the price of our drug,
gotcha.
which means that the relevant hospital has to
Pay out of
take
pocket. Yeah,
profit line.
yeah, that delta is going to be quite intriguing. Uh, so you mentioned that there's ongoing discussions about phasing Vank out as far as the treatment for C. diff. When might that happen?
Well, this is all secondhand, but what I hear is that, as I mentioned, with the approval of the next therapy to treat C. difficile
Mhm.
that's effective, that has promising data, then they'll start phasing out vancomycin out of the IDSA recommendation list.
Gotcha. Um, John's asking, what's the market value for the drug in North America? I think if you were to use, kind of the intrinsic value as you've been discussing.
Yeah, that's another thing we can't comment on. We think it's a lot. What we can say is, we see it if it's used frontline, we see it as $550 million peak year sales per year.
So feel free to run whatever discount rates and all that using your handy investment calculator.
Exactly.
Any updates on the Pasteur Act? I read that the answer is, I assume, no, as far as
Well, with an asterisk, we did cover this on the earnings call. The Pasteur Act, we don't have an update on, except there's something similar to it that's already a law.
from BART.
And yeah, it's through BARDA, and it's an HHS funded program for Department of Defense to stockpile therapeutics for certain material threats. And Katie Britt is a senator from Alabama. She wrote a letter to HHS just asking, because the antimicrobial working group asked the Senate and the Congress to get involved, just asking for this particular regulation, not law. The law's already passed, the funding's there, but they want to open up the scope to include antimicrobials that treat life-threatening infections as being a material threat, so that it can be funded by BARDA and stockpiled at Department of Defense. So that's kind of Pasteur-like.
Yeah.
And if that gets included into a BARDA RFP, I understand it's for late stage phase 3 antimicrobials that treat life-threatening infections. So that would be, I mean, I don't even know how many there could be that are out there. So that really gets me excited. If it goes anywhere, I don't know if it'll go anywhere. I certainly don't have a timeline about anything that Washington D.C. does,
Well,
but
why?
that's
Yeah,
that's pretty much all I know about that. But it sounds pretty interesting.
it does. And as far as I can think of, and again, you know better than Destiny Pharma is the only kind of relevant player right now beyond Abisa Polstat in this kind of market right now.
Yeah, I mean, last I heard about Destiny, and this may have changed, they got sold to Sabila for
Yeah,
$1 million up front, and then maybe 540 million by the
yeah,
time the last royalty check comes in 20 years.
yeah. It was
I
a
think
very sure.
they're in phase 1B, I think, when they did the deal, but
Yeah,
they're not an antibiotic. I think they're a monoclonal antibody.
yeah, and I think it's nasally inhaled if I remember correctly.
It could be. It's also for reinfections. It's not for frontline use.
Yeah, so certainly curious. Anonymous, again, in a bad capital market, won't a partner offer you 20 cents on a dollar as they can borrow money at bank rate and you cannot?
Would a In a bad capital market, would a partner offer me 20 cents on a dollar of what?
I think, kind of as far as the numbers that they could get. I don't know. If you could, Anonymous, kind of put a little more granularity into the question for David.
Oh, I think I know what he's talking about. He's saying that a partner is going to want to pay us 1/5 of however much they think that we're worth, because they're going to say we can't raise money.
Yeah,
But the fact of the matter is, um, we're going to have so many meetings that we would just go to a different partner, is my guess. It would be up to the board. But also, it's not that we can't raise money. We had a 30 to 35% hit rate in our last effort, which is unusually high for any CEO of a biotech company. So we had millions of dollars wanting to come in. And in fact, if if I had been willing to close at a very low price, we would have. But when we get to S3 land, this
yeah,
is where the pubbers won't even know. I could be out there raising 12 to $15 million, and you'd only find out about it after I closed it.
yeah.
So that's open to us starting December 1st.
Gotcha. Yeah. And no, that doesn't mean, just come back December 1st, by the way, because obviously there is the chance that you're going to have a very willing rest of world partner anytime between. Because
And if I didn't, I wouldn't comment on it anyway.
well, of course, yeah. I appreciate that.
Yeah.
Um, well, let's see. It's 1:40 East Coast time. And David, I don't actually know if you're in Staten Island or if you're right by the Golden Gate Bridge today.
Well,
Um,
that's actually uh, the Verrazano Bridge
oh,
in
it is.
Staten Island. But
Okay.
what I had to do is I had to airbrush the gold color for the horizon. Because in
Yeah.
Staten Island, that's like a dark purple.
Yeah.
No, that's the Golden Gate. I'm just
I
teasing.
figured that. Uh, Someone's asking, how much money did you raise through BioPub? Which I don't know the answer for that.
I mean, 5 years ago, probably when I was 30 years old, I would probably have that number in the back of my head, but I don't know. Not a ton, but a decent amount.
Any plans to reapply for the CarvX grant? Great question, Rich.
The CarvX grant. Um, they invited us to reapply. I think we're gonna have to see what the RFP is. The RFP is not out yet for next year. So
Gotcha.
we gotta see what the RFP looks like to see if we comply, if we fall within it. And then we'll make a decision if we want to spend the money and take the chance. That, by the way, that's not for the lead antibiotic. That's for the
Yeah.
second drug.
And obviously, no news is no news as far as that goes. I assume it's still in IND enabling and all that.
Yeah, it's in the preclinical, the lead optimization.
Mhm.
Um, we hope to be done with lead optimization before the end of the year.
Okay, so it may enter the clinic possibly in 2025.
There's more preclinical stuff to do next year, preclin tox, um, and manufacturing work. So figure the earliest it would go into the clinic is end of 25.
Okay. So, and for those of you questioning all of a sudden, well, where's that money coming from? It's pretty nominal until it hits phase one, really, right?
Yeah, that's right.
Okay. All right. Well, last call for questions. Anyway, David, any parting remarks? Appreciate you being on here. I know we've been kind of doing a little, cat and mouse almost trying to get you on the air, and every time it was close, all of a sudden, well, something material's coming out, or then it's earnings, and then it's, kind of got to find the right time that's not a quiet time.
Well, today was a good time. It was We had earnings on Wednesday, so
Yeah,
I'm always happy to be with you, Jonathan, and thanks for all the good questions.
I appreciate that. David, appreciate the all the good answers and all the good data from the drug. And here's to a very different atmosphere in the next few months, hopefully, when you know, if you can get a partner, if you can kind of get all these things lined up as you think they will. And I'm very excited for the future.
Excellent. Well, thank you for your time and for the questions from the pubbers. Always
Yeah.
appreciated.
All right. Thank you, everyone. Have a great day. See you in the pub.
Cheers.